Good evening, ladies and gentlemen, and welcome to the Day 3 session of the First Asian Oncology Society Conference. We will be meeting the experts on lung cancer tonight through a series of lectures. To introduce the first lecturer, may we call on Chairperson Dr. Dennis Sacdalan, the Director of the Cancer Care Center at the Manila Medical Hospital and Medical Center, where he also heads the section of medical oncology. Aside from this hospital, he also practices his profession at the Medical City, where he sits at the Institutional Review Board. Dr. Sacdalan holds many positions in the University of the Philippines or UP. He is a clinical associate professor of medical oncology at the UP College of Medicine and is a member of the UP Manila Cancer Research Technical Working Group. He is also a member of the UP Manila Research Ethics Board and the UP Philippine General Hospital Colorectal Polyp and Cancer Study Group. He is a member of the Philippine Subspecialty Board of Medical Oncology. Dr. Sacdalan is a medical consultant of the pharmaceutical company BioOnco Incorporated. He has a keen interest on research for colorectal cancer and has several publications on this. May I call on Dr. Dennis Sacdalan to introduce the first lecturer?
Good evening, ladies and gentlemen. I'm Dr. Dennis Sacdalan, and I'll be the chair for this session. We have interesting topics for tonight as we meet the experts and listen to their opinions on the management of lung cancer. Let me introduce to you our distinguished speaker, Dr. Alexander Drilon, who will talk on precision medicine, targeted therapy for driver-positive cancers. Dr. Drilon is the clinical director of the Early Drug Development Service at the Memorial Sloan Kettering Cancer Center in New York, where he is also an assistant attending physician of the Thoracic Oncology Service. His research focuses on the development of targeted therapy for genomic subsets of lung cancer and other solid tumors, including cancers that harbor fusions involving ALK, ROS1, RET, and NTRK 1, 2, 3, and MET exon 14 skipping alterations. He was a recipient of the American Society for Clinical Oncology Conquer Cancer Foundation Career Development and Young Investigator Awards, and has been awarded grants from the International Association for the Study of Lung Cancer and the Lung Cancer Research Foundation. He is a member of the editorial board of the ASCO University. So ladies and gentlemen, let us all welcome Dr. Alexander Drilon.
Hi there, it's Alexander Drilon. I'm the chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center, and I'm a medical oncologist. Thank you for the invitation to give this talk today on precision medicine in the era of comprehensive genomic profiling. These are my disclosures. In the first section, we're going to begin with the fact that the number of clinically actionable genomic drivers are certainly on the rise in the last couple of years. And perhaps the poster child for a cancer that's enriched for many of these genomic signatures is, as you know, lung adenocarcinomas. And in this slide, we're showing you data from our internal next generation broad hybrid capture sequencing assay called MSK Impact, where we profiled 860 lung adenocarcinomas, all of whom had recurrent or metastatic disease. And you'll see the fruits of that endeavor here. I'll have you focus first on the pie chart on the very left, showing you that in the late 90s, essentially the only mutation that we knew was present as a strong driver of cancer in these lung adenocarcinomas were hotspot KRAS mutations. But fast forward to 2020 in the pie chart in the middle, you see that the unknown molecular driver slice has certainly gone down from 75% to 12%. And the rest of that pie has nicely filled in with multiple different genomic signatures, of course, of varying levels of clinical actionability, ranging from those which have FDA matched or regulatory agency matched approved therapeutics to those that have data in preclinical testing on their actionability. And in addition, before we leave this slide, you see on the right that a very comprehensive assay has the advantage of elucidating the co-mutational landscape of these tumors. And now more and more, we're finding that some of these co-mutations that are passengers seemingly on top of a canonical driver may serve as modifiers of benefit. Certainly, we've seen, for example, that TP53 mutant cancers, in addition to a canonical driver, may have an impact on progression-free survival. And also point out that in terms of immune therapy biomarkers, that we've realized that KRAS mutant lung cancers that may coexist with STK11 or KEAP1 alterations do less well with immune checkpoint inhibitor therapy. And interestingly, also with regular cytotoxic chemotherapy for some reason. But certainly, what's more familiar to you is the fact that the list of actionable oncogenes with match therapeutics on a regulatory front has certainly grown. And we'll start on the very left of the slide, where you'll see that in late 2003, we knew about sensitizing EGFR mutations, moved 4 years later towards the discovery of ALK fusions. And now in 2020, we have a panoply of different other signatures that are matched to single agent or combination therapies or therapies on clinical trials, which have shown very exciting activity. So the field is changing very rapidly for patients in terms of therapeutic options. And that applies not just to lung cancers, but also in other cancer types. And so here in this slide, we'll focus first on the left, where you see that there are a number of different histologies which may harbor some degree of dependency on the FGFR family members. And you'll note that in particular, if these cancers harbor FGFR2 or 3 fusions, in addition to the other alterations such as the copy number changes that you see here, that they may stand to benefit from FGFR-directed tyrosine kinase inhibitor therapy. And you'll note in the two bullets that there are drugs that have already crossed the regulatory finish line, like the pan-FGFR inhibitor erdafitinib for urothelial cancers, or the FGFR1 to 3 inhibitor pemigatinib for cholangiocarcinomas. On the right, we'll also note that a recent approval has been the approval of selective RET inhibitors for RET-dependent cancers. And I'm sure all of you are familiar with, as we just saw in the last two slides, these RET fusions that are enriched in and are known to drive non-small cell lung cancers. However, I'll remind you that the fusions were initially discovered in papillary thyroid cancers. And in addition, RET mutations, either of the kinase domain or the extracellular domain, are known to drive medullary thyroid cancers, or MTCs. And those can be both somatic and germline. And here you'll see the activity, the waterfall plots of selpercatinib for patients with RET mutant MTCs. And you'll see a nice response to the selective RET inhibitor, especially in patients who have been pre-treated with prior suboptimal multikinase inhibitor therapy. And in this next slide, we go back again, the data from our institution with MSK Impact, showing you that if you focus on the far right, the number of other tumors which may harbor these actionable signatures, and these are broken down for you in the different colors in these bars by the levels of actionability. So you'll see on the upper left, we move from level 1 to level 3B with various levels of evidence. And you'll note the long tail, we say, of these alterations in the lower left, applying not just hotspot alterations or mutations, I should say, in particular genes, but also copy number alterations and recurrent gene rearrangements. And talking about poster children, as we have in a previous slide, we of course know that the poster child for a fusion that's known to sit in many different cancer types of varying frequencies are these NTRK1, 2, and 3 fusions. And here you see the registrational data sets, recent updates showing the activity of the first generation TRK inhibitors, larotrectinib, which is a selective drug, and entrectinib, which is a multikinase agent, which also has some activity against ROS1, for which it has a separate indication. But shown here are the fact that the majority of patients will have disease regression with this therapy. You see very deep responses, confirmed complete responses across many different tumor types, and response rates that approach 60 to 80%. And with the larotrectinib data set probably ahead in terms of the amount of follow-up, you'll note that the median duration of response and the median progression-free survival were very long at almost 3 years and north of 28 months, respectively. So we do really well for patients with these therapies that are matched to the genomic signatures in their cancers. And the next slide is a busy one that only really tries to make the point that even beyond the cancers that we discussed, there are many other potential matches, such that if you employ a comprehensive sequencing platform and find these, you open up treatment options for your patient, not just on the standard of care front, but also in terms of clinical trials that are going on around the world. In the next section, and because of what we've seen in the first section, I'll highlight how we've really observed a diagnostic migration towards more comprehensive sequencing approaches. And I'll share with you the journey that we've taken at our institution in terms of sequencing. And I'll highlight that the old algorithm that we have is what I like to call piecemeal sequencing, or maybe we had a few single gene assays and some polygene assays that were employed to test particular cancers like lung cancers. However, we then asked ourselves the question, is it useful to do next generation sequencing for those patients with for whom, excuse me, piecemeal sequencing may not have identified a mitogenic driver? And you see the results here of the apparent driver negative cases with the old sequencing algorithm, then undergoing next generation sequencing with the Foundation One platform. And you'll note in the pie chart that about 1 out of 4 cases, there was a canonical driver that was missed by prior piecemeal sequencing. And in an additional almost 40% of patients, there was a genomic alteration that was detected that opened up the opportunity of joining a clinical trial that was open at that time. And of course, the question then becomes if NGS is better poised to pick up a wider swath of alterations, both known and on a discovery front, which will open up clinical trial options, is cost a problem for such a pursuit? And thankfully, we have some data that's come out highlighting that next generation sequencing in general can decrease cost compared to older panels. And I'll refer you to this paper published by Dr. Pennell and colleagues on the economic impact of next generation sequencing. Very briefly, they looked at older approaches such as sequential testing, exclusionary KRAS testing, and a mix of particular hotspot panels and single gene tests similar to what we've done at our institution, and compared those 3 approaches to upfront next generation sequencing. And the punchline really is in that last bullet at the bottom of the slide, showing that although the unit cost of next generation sequencing was higher than the individual single gene tests, the overall cost, including testing and the rebiopsy costs, were lower if you considered NGS over the other 3 strategies. And I'll drill down on a point there and note that the prior algorithm, where we did a couple of tests in sequence, more often than not, we ran into issues of tissue exhaustion that required us to approach the patient again for acquisition of more tumor tissue, which not only comes with costs, but also with certain consequences for the patient and fatigue in terms of diagnostic procedures. But how have we moved beyond even just comprehensive sequencing of tumor? Well, we know that we now are able to lean on complementary approaches that interrogate blood. These are the liquid biopsies that can serve as a very effective complement to tumor biopsy-based sequencing. And as you know, cancers can shed tumor DNA into the blood that can be interrogated with targeted next-generation sequencing assays that often have a turnaround time that's shorter than a much more comprehensive tumor-based next-generation sequencing platform. The example on the left is that of a patient with an EGFR T790M mutation that was found earlier because of blood, resulting in earlier matching to targeted therapy and, of course, faster benefit. And that's highly valuable for patients who may have a very high disease burden and are very symptomatic of their cancers. But that is not just limited to EGFR. You'll note on the right that one of the newer drivers, MET exon 14 skipping alterations in lung cancer, can also be detected in blood. And based on the results that you see here of the ctDNA cohort of the Profile 1001 study, if you find something on blood, you can generally trust it, proceed with targeted therapy, and patients will benefit in the same manner that they benefit if you find something on tumor-based sequencing. But what's another layer of moving beyond the typical only screening with tumor-based DNA-based NGS assays? Well, something else that we've discovered on our journey is that even with our best DNA-based next-generation sequencing assays, those tests may not be poised to detect all alterations. And one thing I'll call out here is that the recurrent gene rearrangements are interrogated on DNA by what we call tiling of these intronic regions where these recurrent breakpoints occur. And that can be very challenging, as you see in the blue box on the right, when the intronic regions are very expansive, as with NTRK 2 and 3, or where you have repetitive elements at the fusion breakpoints, as is the case for ROS1 fusions. However, if you then rely on RNA-based sequencing, where you have the final gene product with only the coding exons that are targeted and the intronic regions excluded, it can be easier to find these. And we again asked ourselves that question. We did a study where we looked at our MSK impact hybrid capture sequencing apparent negative cases. And in almost 15% of cases, we found on RNA-based sequencing with anchored multiplex PCR, an actionable driver, such as the various fusions that you see in the pie chart in the middle, ROS1, ALK, RET, and NRG1, and in addition found these MET exon 14 splice site alterations that were missed by DNA-based NGS testing. And of course, with the discovery of these, we sequenced patients onto target therapy, as you see on the right, and several of them unsurprisingly benefited from treatment. But we're trying to move the needle in the space, and at our center and at many centers around the world are looking at ways of leveraging next generation sequencing to drive not only standard of care therapy, but also clinical trial matching. And what we've done is that we've partnered with our systems folks to essentially have the reports that are generated by our next generation sequencing assays paired with an online database of OncoKB, which you'll see in a second, that's annotated by the genomic variant and level of evidence, format that into a report that's easily digestible by the clinicians, and send that not just to the primary medical oncologist of the patient, but also to principal investigators who have trials for which a genomic signature that's detected by NGS might match patients to that particular protocol. And I promise I'd talk about this, but this is the OncoKB database that's used in our particular reports, which ranks these different alterations by level of evidence. And this is a resource that's available to all of you. If you are in a situation where you are faced with a molecular report where there are alterations of unclear significance, you're able to pull up this website. This is publicly available. Type in the particular mutation, and it'll spit out the level of evidence to hopefully help you decide on potential targeted therapy for your patient. But as I mentioned, because of this systems integration, this enterprise scale next generation sequencing has certainly driven accrual also to our clinical trials. And here I'll single out again the TRACK program, with which we had put a substantial number of patients on the larotrectinib trial, resulting in this drug receiving registrational approval for TRAC fusion positive cancers in an histology agnostic fashion. Now, another question that's often asked is, can I stick with next generation sequencing platforms that maybe just have the 5, 6, 7 genes of interest for my particular cancer? Is there any benefit to doing more comprehensive next generation sequencing tests that offer up to hundreds of genes? Is there something that is afforded by that kind of sophistication that has meaning in terms of practical value for our patients? And the answer at our institution certainly, and has been seen with many other different assays, is yes. So here I'll highlight that next generation sequencing is poised not only to detect somatic alterations, but also germline alterations. And some assays will employ a computational algorithm that filters out these germline events versus those that are somatically acquired. But other assays, like our assay, will also feature the matched normal blood sample. In our case, it's a blood draw, matched normal blood draw that's acquired in order to run this test and filter out the germline alterations. And here you're seeing our experience again with about 16% of cases harboring a potentially pathogenic germline variant, and 5% of cases having an actionable alteration, such as a BRCA inactivating alteration. And we've seen that that's extended to other tumor types as well. Here you see the fruits of PARP inhibition in other cancers, such as pancreatic cancer. You'll see the POLO trial where maintenance olaparib beat placebo. And then on the right, you have the Triton-2 trial of rucaparib in prostate cancers, including those that have germline alterations in DNA damage repair. Our assay, again, in addition to other assays, can elucidate certain mutagen signatures, as you see on the upper right, such as UV, smoking signatures, etc., that may inform disease etiology and help on sort of a biologic or epidemiologic level. But beyond that, I think on a practical therapeutic level, these comprehensive assays are able to tell you tumor mutational burden, and you see the violin plot of that calculated across cancer types for our NGS assay. And beyond immunohistochemistry can also detect things like MSI status, so microsatellite instability. And as you know, for patients whose cancers have an MSI high status or those with high tumor mutational burden, we now have regulatory approval of pembrolizumab in a tumor agnostic fashion for those patients. Another thing I'd like to call out is that now that we're interrogating different tissue types, this problem of clonal hematopoiesis has emerged. And essentially, in a nutshell, we know that the hematologic compartment over time can acquire genomic hits that have an implication in terms of potentially developing a hematologic malignancy down the line, and sometimes are associated with higher risks of cardiac disease. In particular, that can happen in patients that have had cytotoxic chemotherapy, for example, where you see these modifications emerge in the bone marrow. And here again is data from our institution in more than 17,000 patients, showing that 26% had these CH or clonal hematopoiesis alterations in blood, and 14% of those find their way with these hematologic elements into the tumor itself. Now, this is certainly an area that has the potential to trip you up, because as you see on this slide, some of these CH mutations may be categorized as quote unquote actionable and potentially lead to erroneous treatment recommendations. So here, for example, you see at the very bottom, a hotspot KRAS G12R mutation. It's not unreasonable to think that you might see a G12C alteration in blood that you might think is coming from the tumor. And now we have these selective mutation-specific G12C inhibitors that have shown promise in clinical testing. There are these IDH mutations that you see here, BRCA mutations, for example, P10 mutations, which might open up clinical trial options for your patients. And so very carefully, I think we have to look at these molecular reports, sometimes take them with a grain of salt, but more importantly, really kind of take a deep dive and focus on trying to filter these out for the clinician so that they're really identified as coming from a different compartment versus the tumor itself. And we're able to do that, for example, because we have the matched normal blood sample where you can see these CH alterations, which of course shouldn't be detected in the cancer cells themselves on a tumor biopsy. Now, in the last section, I'll just focus on a few other things that our next generation sequencing is able to do for us. We've tried to leverage NGS to really advance our understanding of cancer biology, recognizing that even with our clinical grade next generation sequencing assays, that these have an element of discovery And here we're showing you a paper again from our institution showing that certain variants of unknown significance or VUSs may actually be clinically actionable. And the example here are these AKT1 or 2 duplications, which were found to be oncogenic based on certain features that are vetted on a computational level, such as recurrence and paralogy, etc. And it's interesting that in this case, there were paralogous AKT1-2 hotspot duplications that were identified, and that was found on a computational front before it was then explored post hoc in the laboratory, in vitro and in vivo. And from the same paper, we see that that applies not just to that singular experience, but also potentially to many other genes, as you see in the plot on the far left, such as MET, for example, PTEN, mTOR, where we're only beginning to see acceleration in the number of potential hotspots that are identified. And so on the right, are we now in a situation where we're able to use prospective sequencing, computational vetting to really validate some of these former VUSs and therefore bring them to clinical testing even before they're biologically explored in the laboratory. Other examples of what sequencing is able to do is what NGS offers on the resistance front. And this is a case that takes us back again to the selective RET inhibitor space. Here we see on the left a paper published showing that these RET fusion positive lung cancers at the onset of resistance can acquire these solvent front substitutions that have steric penalties for these selective RET inhibitors. But thankfully, because rational drug design has anticipated the development of these solvent front mutations, now we have next generation RET inhibitors that may work for cancers that acquire these mutations. And in fact, that's happening also for other fusion genes like NTRK. And here we see rationally designed next generation drugs as shown in the orange bars, such as selitrectinib or repotrectinib. And this is a case of a patient of ours with a mammary analog secretory carcinoma, harbored an NTRK fusion, had a very durable response to entrectinib. On resistance, the cancer was rebiopsied. It was not hard to do with this patient, as you can see. And the cancer was found to acquire a solvent front mutation for which repotrectinib had activity against in vitro and in vivo. The patient got the drug on a clinical trial, and you see the cancer nicely melts away again with the sequential TKI approach. So that's a lot to digest, and in the summary slide, I hope we've shown you that the list of actionable molecular drivers with approved targeted therapies definitely continues to grow. Comprehensive DNA and hopefully RNA-based cancer sequencing is able to improve the detection of these clinically actionable drivers versus older strategies and can potentially be cost-saving for patients and payers. Next-generation sequencing can also detect potentially pathogenic germline variants, clonal hematopoiesis, potential immunotherapy biomarkers, and other exogenous mutagen signatures. And finally, as we spoke about in the last section, NGS assay data can be leveraged to aid driver discovery, capitalizing even on computation analyses, and develop prospectively monitored cohorts that aid therapy matching. And with that, thank you very much for your attention. It was a pleasure to give this talk, and thank you again. We certainly live in very trying times with the coronavirus pandemic, and we've been asked to share best practices. I think that on my end, I'd like to share what we've done on a clinical trial front. And thankfully, both regulatory bodies and our institution have released guidelines that have increased the flexibility with which we're able to continue to see patients on these trials. We've leveraged telemedicine or video visits to perform the standard face-to-face visits that we see for patients, particularly if it's visits which aren't very complex and don't have long day PKs, for example. And that's particularly useful for some pill-based therapies for which we're able to mail these to a patient's home and they can continue getting their treatment. So I definitely think that this is a best practice that's emerged during the time of COVID. I certainly also hope that some of this will continue even after things have calmed down post-COVID, because as we know, this is a huge advantage for patients, and is a practical approach, especially for visits that are not overly complex.